Hi, Dr. Brian Kaufman, a retired family doctor and the co-founder, Executive Vice President, and Chief Medical Officer of the nonprofit CLL Society. And I'm here to present some important abstracts that have recently come to light, including one from iwCLL 2023, the International Workshop on CLL, on new results with the bispecific antibody Epcoritamab in relapsed or refractory RR chronic lymphocytic leukemia. What's the bottom line on this? Epcoritamab, a novel subcutaneous bispecific antibody, resulted in a 62% response rate in a high-risk, difficult-to-treat relapsed refractory CLL patient population. And so far, those results seem quite durable. This research was led by and presented by Dr. Arnon Kater from Amsterdam, the University of Amsterdam, Netherlands, and he presented the results at iwCLL held between October 6th and 9th in Boston, Massachusetts. In the way of background, despite the progress in CLL therapies, new therapies are still needed for patients who've been failed by both the BTK inhibitors like iWCLL, acalabrutinib, zanubrutinib, and by venetoclax. These patients are usually very difficult to treat and often have high-risk prognostic markers, including TP53 and/or unmutated IGHV. Epcoritamab is a novel subcutaneous below-the-skin bispecific T-cell engager, or BiTE, monoclonal antibody that binds to CD3 on the surface of T cells, the cellular part of the immune system, and CD20, which is found on CLL, but also on normal B cells. It brings the T cells next to the targeted CLL cells that are marked for destruction. As such, it's an immune therapy that's quite similar to CAR T, but is available, quote, off the shelf, close quotes, and is not made up of cells, but of antibodies. It's already approved by the FDA in the use for relapsed refractory diffuse large B-cell lymphoma, DLBCL. The Epcor-CLL1 study, which was presented at ASH 2021, showed encouraging efficacy and manageable safety in relapsed CLL and Richter's transformation. These data that we're presenting, that I'm sharing now, are the expansion of that trial and the first new results in almost 2 years on Epcoritamab. There were 23 patients enrolled. The average age was 72, so pretty typical. 74% were male, again pretty typical. 70% had the bad marker of IGVH unmutated, and 65% were TP53 aberrant, not good. Patients averaged 4 prior lines of therapies. 100% had had a BTK inhibitor, 100% had a prior chemotherapy, and 83% had a BCL2 inhibitor such as venetoclax. This was a tough group to treat. Epcoritamab was ramped up over 3 weeks to its full dose of 48 milligrams given subcutaneous, and it was given with a steroid prophylaxis to prevent cytokine release syndrome, or CRS, which is commonly seen in immune therapies. Cytokines are inflammatory enzymes that are released when there's a lot of killing of cancer going on. It's sort of collateral damage. The shots were infused weekly for the first 12 weeks, then bi-weekly for another 12 doses, and then every 4 weeks until intolerance or progression. The primary endpoint of the study was overall response rate, but complete response, time to response, and safety and tolerability were also studied. So what were the results? Before we get to the efficacy, let's look at the adverse results. 100% of patients had cytokine release syndrome, with the most common being grade 2. So grade 2 is mild, but there may be some drop in blood pressure or a drop in oxygen saturation. There were grade 1s and some grade 3s, but no severe grade 4s where patients needed deep and active therapy, and there was no CRS-related deaths. 100% of patients had CRS with the first full-strength dose of 48 milligrams, but it was not uncommon to be seen at other doses and to be recurrent. Other adverse events included low platelets, seen in 60%, anemia in 56%, low neutrophils in 39%, peripheral edema or swelling in 47.8%, diarrhea in 43%, fatigue in 43%, and pneumonia in 30%, including one treatment-related death related to pneumonia. However, most adverse events were mild, but there were 3 deaths, 2 from pneumonia, though only 1 was considered treatment-related, and 1 from a squamous cell carcinoma of the skin. What about the efficacy? Overall responses were seen in 13 of the patients studied, or 62%. Complete responses were seen in more than half of those, 7, or 33%. Partial responses in the other 6, 29%. Stable disease was the outcome in 4 patients, or 19%. Only 1 patient, or 5%, had progressive disease. Encouragingly, response rates were similar regardless of the patient's risk characteristics, whether they were TP3 aberrant, whether they had double refractory disease. And responses were really quick. The median time to response was 1.9 months, and to complete response was only 3.6 months. So what can we conclude? In a difficult to treat, high-risk population of patients with relapsed refractory disease, most of whom have been double exposed to venetoclax and a BTK inhibitor, Epcoritamab subcutaneous showed very encouraging results. Responses were seen quickly and often, with an overall response rate of 62% and a complete response rate of 1/3, and appear durable, with an estimated 83% of patients remaining in response at 9 months, the length of the follow-up that was presented. Safety was manageable, and it's what you'd expect with these T-cell engaging strategies. There were no new safety concerns discovered. CRS events were seen in all patients, but were mostly low-grade, and all were relatively short-lived, and despite being quite unpleasant to go through, none led to discontinuation of the trial. Epcoritamab appears to be a promising new option for patients with very few options who've been through multiple lines of therapy before. Thanks for listening. Stay strong. We're all in this together.